the reason why I'm here, I suppose, is because I've been using Xamiol's been launched about 2 years ago, and so I do have clinical experience in using it. And so, what I want to do in this evening's presentations is to explain to you what treatment options there are for psoriasis of the scalp, and where you might want to consider placing Xamiol within that range of treatment options. There are some slides here which I'll skip over quickly because you're all dermatologists, and some of the slides here are perhaps a bit too basic for the quality of the audience that I'm talking to this evening. Scalp psoriasis is the commonest aspect of psoriasis, and even for someone who has an interest in psoriasis, I often forget to ask specifically about scalp psoriasis. And since Xamiol's been around for the last 2 years, and it's because it's been such a good product, it has prompted me more to be a little bit more specific and making sure that I do mention and ask about scalp psoriasis, because of all the types of psoriasis, it is difficult to treat and frustrating to treat, and often requires help, time and investment of time by both the doctor and the patient. So scalp psoriasis, very common, and occurs between 50 and 80% of patients who have psoriasis, and it can occur individually or with other aspects of psoriasis. And psoriasis itself is quite a common condition. Worldwide prevalence is up to 4% in some studies. The genetics, you already know, it's an inherited condition, several genes implicated, but it's a complicated form of inheritance. When we look at treatments for psoriasis, we can divide them up into treatments which are anti-inflammatory or reduce keratinocyte turnover. And a lot of the drugs, we know the mechanism of action, and they can be quite specific to specific interleukins and certain ways of suppressing the T cells, which are important in developing psoriasis. Also, keratinocyte turnover appears to be quite important, and if you look at vitamin D analogues, they appear to be both anti-inflammatory and reduce keratinocyte turnover. This slide depicts that the antigen-presenting cell appears to be perhaps the most important cell involved in promoting the development of psoriasis. And with the advent of biologics, drugs which are specific at knocking out certain T cell receptors and certain interleukins have shown us that pathways such as the T17 pathway seems to be very important in the development of at least moderate psoriasis and severe psoriasis. But that's not quite the whole answer. My colleague Jonathan Barker at St John's wrote quite a nice paper early this year in the British Journal of Dermatology, looking at a slightly modified fibronectin, which seems to drive keratinocyte turnover in a totally T17 independent pathway. So having drugs which attack both the anti-inflammatory pathway and the keratinocyte turnover pathway are important, and vitamin D analogues, as I mentioned, do straddle both of those pathways. Pityriasis mantasea is meant to be a precursor of psoriasis. You see it in children and young adults. It has an eczematous or an eczematous or psoriatic histology. But if you look at psoriasis itself, very different from pityriasis mantasea in the scalp. And the cardinal features that seem to be important are itching, scaling, the obvious plaques, the alopecia that can develop, and of course the cosmetic embarrassment. This is my daughter, Sarah. I needed a slide to try and depict the itching, and she says, "Don't worry, Daddy, I can do that for you." And I think she's acting it out there quite well and quite effectively, I think. If you take histological samples from scalp psoriasis, there's a marked atrophy of sebaceous glands, and that's probably what's driving the itching, which is a significant symptom experienced by patients with psoriasis, but seems to be less important in psoriasis plaques elsewhere on the body. The scratching obviously accentuates the psoriasis because of the Koebner phenomena. And if your patient is complaining of itching, coal tar products and topical steroids are very helpful in that, whilst other products such as any alcoholic-based preparation or calcipetrol can often make the itching worse. Alopecia can be scarring and non-scarring, and a number of observations have been made with this. You get excess shedding of telogen hairs, decrease in hair density, finer hair shafts, and miniaturized hair follicles. This is a dermatoscopic image of the hair, and you can see on the one side the psoriasis plaques, but more towards the center of the plaque, you can see some hair follicles with hair shafts growing out of it, and you can see some hair follicles without any hair shafts. But you can also see quite large distances between the hair follicles, signifying an atrophy, a complete loss of hair follicles, which is a scarring alopecia. In these areas, a granulomatous foreign body reaction is occurring, causing this scarring alopecia. Now, most patients with scalp psoriasis, when they get alopecia, will get their hair regrowth back, but it's not always the case. And I'm slightly more reserved in patients who have lost hair as a result of psoriasis in letting them know that everything will come back again, because it doesn't always. The psychological impact cannot be understated with this condition. If you look at DLQI scores and assess and compare them with the severity of psoriasis and the location of the psoriasis, the DLQI scores are much higher in areas where the psoriasis is more visible. So that's going to be the face, the scalp, the hands, and also the genitals as well. And not so much with the disease severity. So if you manage scalp psoriasis very well, then you will see a marked improvement in the DLQI scores. As already mentioned, patients who have scalp psoriasis will tend to avoid a number of activities, including swimming, certain clothes, and certain sports. And when it comes to scalp psoriasis, going to the hairdressers and wearing dark clothes. Van der Kerkhoff published a study looking at the psychological impact factors, and in scalp psoriasis, it's the scaling, the itching, and the visibility which affect the patient most markedly. You can't use a PASI system to assess scalp psoriasis. There is a 7-point scale system which is used in clinical trials to help evaluate psoriasis, and it's worth looking at because it does highlight the factors which are important to the patient: the itching, the amount of coverage, the flake density, the amount of scaling they're getting, the degree of alopecia, the quality of life impact, and so on and so forth. You're all very good dermatologists, so it's unlikely that you're going to be find it difficult to tell psoriasis in the scalp from any other condition. Perhaps seborrheic dermatitis is probably the only thing that can sometimes be a little confusing, particularly if the seborrheic dermatitis is mild or the psoriasis is mild, because those two can look quite similar. Often when seborrheic dermatitis is more florid, then it's much easier to identify it as that rather than psoriasis. And it's a totally different disease anyway. Seborrheic dermatitis can mimic psoriasis in its distribution, and so sometimes it can be confusing if you're not that experienced. But the plaques tend to be much more yellowy, orangey, and greasy. And if you were to biopsy it, then you'd find a histological inflammatory process rather than a psoriatic one. There's also a lack of family history of psoriasis, and this condition won't respond to antifungal shampoos. Like seborrheic, and psoriasis won't respond to antifungal shampoos where seborrheic dermatitis will. SIBO psoriasis, well, I'm not too sure where that sits. It probably means that the individual both has seborrheic dermatitis and psoriasis. And when I'm faced with a patient like that, I tend to treat them with topical steroids because it will clear out both conditions quite effectively. So a 24-year-old woman presents with a thick scaling on the scalp. She's been using a tar-based shampoo, betamethasone valerate scalp application. She's concerned about a hair loss. And there she presents, and you can see the psoriasis in her scalp. Easy, isn't it? That's all she's got, psoriasis. No need for any further assessment, write a prescription, off she goes. But it's not quite like that. If someone presents with psoriasis in one part of the body, you've got to look for psoriasis elsewhere. And as you can see, she's moving her hair to show you the front of her scalp. She's obviously got it on her hand as well. We have 15 minutes for a first consultation with patients in the UK. I don't know how long you give your patients per consultation. And in that first consultation with someone who doesn't know that they've got psoriasis, you've got to discuss a lot of different things. The genetics, the fact it's a chronic condition, the fact that it's a relapsing condition, that it's all about control and not cure, and they will have to invest time into manage their disease effectively. And you've also got to try and be understanding and empathetic as well about their condition. And then on top of that, explain how to use the treatment. And when it comes to scalp psoriasis, because scalp psoriasis treatments are quite complicated, then trying to pack all of that into a single consultation can be quite demanding. you can approach treatments by looking at the drug class or the vehicle that you're using to deliver that drug. So you may choose a vitamin D or a vitamin A product or a tar product or so on and so forth. Or you may look at that patient and think, well, that patient's more likely to want to use a shampoo or a lotion or a gel for that part of the body. A gel may be more appealing or more useful than an emollient. In scalp psoriasis, being a hair-bearing area and often with thick scale, I like to think about it as negotiating the deal. First of all, you need something to shift the scale, and then something to remove the descaler, and finally an active product to actually get to the psoriasis itself. Traditionally, the shifters of scale are things like yellow soft paraffin, cocois, which we use as a coconut tar salicylic acid ointment, arachidol, coconut oil, or stronger concentrations of salicylic acid. And they're all quite good at shifting the scale. This is an example of a patient who's using a low percentage tar product on the scalp. There's a nurse applying the product as the descaler, and it's clearly a time-consuming process for that patient. From the patient's perspective, the scalp is relatively inaccessible because all the hair's in the way. The descaling products are cosmetically unacceptable, they're difficult to apply, and those factors will reduce compliance. Patients do not like time-consuming, messy, smelly, sticky treatments. But they do work. One small study shows that salicylic acid gel does reduce the severity of psoriasis purely by its descaling action. But surveys of patients show that patients do not like using these scalp treatments, and they don't use them, and they cite things like forgetfulness, lack of efficacy, lack of time, difficult using product as all reasons why they're not using this triple approach that you've requested them to use. So you've managed to convince your patient to use a descaler, and it's worked. You now need something to shift the descaler. So you're going to use a shampoo. And most of the shampoos that are around are tar-based shampoos. Some of them have a bit of salicylic acid in them, and these are the ones available in the UK. Tar shampoos, people have different likeness to tar shampoos. Some patients love the smell of tar, and others can't stand it. And you either like it or you don't like it, and if you don't like it, you're not going to use it. But they are very good for improving the itch. If you use descalers, such as a vegetable oil in one study, followed by a coal tar shampoo, you can actually get good long-term remissions with scalp psoriasis, but it's a very time-consuming process and relies on the patient being quite dedicated using the treatment. We've got a product called Dermax shampoo, which is probably quite good for seborrheic dermatitis. It's got benzalkonium chloride, which kills Malassezia furfur. And it's meant to be negatively charged, lift out the scales, that's what the company says. But it's quite a soothing product to use on the scalp. There was an aborted trial years ago using ketoconazole to treat scalp psoriasis, which showed that the condition actually did improve. So there may well still be some crossover between seborrheic dermatitis and psoriasis in the scalp, and a role to play for that particular fungus. So use your descaler, you've removed the descaler with your shampoo, you now need something active on the scalp. And your options are topical steroids, calcipotriol, topical dithronol cream, coal tar solution, but now Xamiol gel.